Well, why don't we
Yeah.
can get started with the people that are on. Chris and Rachel, I don't think I know you guys. Is this, but I'm looking at the attendance list. Is your last name Love?
Hi.
Hey.
Yeah, it is. I'm Chris. This is Rachel, and this is Cece.
Oh, hey, Cece. Where are you guys from?
Portland, Oregon.
Oh, okay. Well, welcome. So I'll start with I don't know, you probably haven't been to these before, but it's really a free for all. Like I'm just here to help. I was a heart surgeon for 30 years, most recently in British Columbia from 2010 onwards. I stopped doing surgery at the end of last year, but this is a way to sort of keep connected with parents and try to help them navigate through the waters. So you had a question, I think, regarding sutureless repair for pulmonary vein stenosis. Can you tell me the context of what you're talking about? Because it matters a little bit. So I assume Cece is the patient. And
She is.
what was she born with, and what has she had done?
Let's see. So she was not born with any cardiac abnormalities seen initially, besides like a PDA. She came at 30 and 5 weeks without clear reasoning that we ultimately found was related to Russell-Silver syndrome, which we weren't familiar with. She had lots of normal echoes in the NICU, and then at a follow-up visit to cardiology a month after we left the NICU, just to look for pulmonary hypertension, they didn't see any, but unfortunately they found pulmonary vein stenosis. So our journey since that time has been 5 caths, most recently last week. She has 3 stents to her left lower, left upper, and right upper. And our interventionalist, who we love dearly, feels that we are at the point that we need to consider sutureless repair.
Yeah. Okay, so this is something that happens in the context of preterm infants, de novo pulmonary vein stenosis. It's not like there's different types of pulmonary vein stenosis. Most commonly in the cardiac world, we see them we see them after a repair of kids that are born with what's called anomalous pulmonary veins. But there are also some kids that just get pulmonary vein stenosis de novo, and oftentimes they're the premature ones. So the stent thing is quite controversial in those cases because stents tend to palliate kids for a while, but they don't lead to long-term success usually. And then sometimes they're harder to deal with when the stents are in place when it comes to surgery. As far as sutureless repair goes, it's a bit of a misnomer. So I don't know what you know about it, but people think, oh, sutureless repair, they're doing it with magic lasers, no sutures. But there are sutures. The only difference is that in traditional pulmonary vein stenosis, you operate on the pulmonary veins themselves. So you open up the pulmonary veins, you patch the pulmonary veins, you connect pulmonary veins that are abnormally connected back to the heart by suturing those pulmonary veins to the heart, whatever. The stitches go inside the pulmonary veins themselves. But what people have postulated is that scar tissue in the pulmonary veins from manipulating them with a suture, whatever, knife, a stent, honestly, can lead to more scar tissue and further problems down the road. So what a sutureless pulmonary vein repair does is it opens up all the veins, and instead of sewing the veins directly, you sew around the vein. So there's a sac that encompasses the heart called the pericardium, and that sac goes 360 degrees around the heart. And so you suture the back of that sac to the left atrium where you make a hole in the left atrium. So you're basically making a new left atrium, and the pulmonary veins are sort of bleeding into that new left atrium. And that way it's a controlled bleed because everything's stuck together to the left atrium, but you haven't actually touched the pulmonary veins. The kicker in this whole deal with Cece is that she's already had stents in it. So her pulmonary veins have already been manipulated. So it's hard to know what that means in the long term. It's also difficult to know what the long term brings because I don't know how far the stenosis extends. Sometimes with pulmonary vein stenosis, is what's called focal. So it's sort of right where the pulmonary veins enter the heart. And sometimes it's more diffuse, meaning the pulmonary vein stenosis goes all the way out into the lung tissue itself. And so the farther it goes, the less beneficial an operation is. But if it's just focal and the pulmonary veins in the lungs themselves are okay, and there's not a lot of pulmonary hypertension, then this approach, the sutureless approach, makes sense. Does that clear that up a little bit?
Absolutely. Yeah. And from the best of our knowledge from the last cath, we don't have any long segment disease. It sounds like proximal, or I guess distal to the stents, they're describing her veins as juicy and large and appropriate sized. So
Yeah,
I think
that's good. The term juicy is always good. That means that there's appropriate dilatation of those veins and areas past the area of narrowing or stenosis. So that makes the outcome a little bit more favorable. The only thing I can't really comment on is what the outlook is given the stents in the pulmonary veins. So when was the last stent placed?
last June, they added the left upper after it seemed they decided it was probably iatrogenic from the left lower compressing the left upper, the stent actually just extrinsically doing it. And so they added the left upper at that point, and unfortunately it's tethered, or fortunately as may be, through one cell, I guess, in the stent. So they're sort of affixed, which is why she thinks we're at a surgical point, because there's a proximal stenosis where the two stents are joined just beyond that, and she doesn't think she can fit another stent there.
Yeah.
With something that would have to be custom made to fit that sort of ostium or whatever there.
And do you know how much pulmonary hypertension there is or there isn't?
There hasn't been any identified. There was I think at one point last year there was some concern, but she hasn't had any elevated right-sided pressures
And
yet
her
from what I hear.
oxygen saturations are normal?
She's on 100 cc's overnight now. We've weaned her down, but she seems to still
So
need that.
what's the push to do something now?
Our interventionist felt that what she could do in there was not going to be temporizing things quite as long with this stenosis. She wasn't sure how it would respond to this very short segment, proximal to the confluence there. She also said that the right upper is pretty significantly re-stenosed inside the stent. So she ballooned it, but she felt that either it needed a new stent to push the tissue back, or she didn't seem to like the idea of stent on stent, metal on metal.
Yeah, no, I agree. That's not a good idea. The only issue is what's going to happen to those stents, because it's almost, if they're all about a year old or older, they're almost impossible to cut out at this point.
Oh, really? Okay.
Yeah, like they're usually just grown into the tissue, so you can't get rid of them. So you basically have to cut through them, and then you just sort of leave part of the stent in place, take out some of the anterior part of it and some of the posterior or the back wall part of it. You usually have to leave in place. I mean, there may be a different way to do it, but typically that's been my experience. So that's why I asked about timing, because part of this is about prognosis in terms of the stents in place, and part of it's the trigger to do something, because pulmonary vein stenosis is a really weird disease. Like sometimes it progresses very rapidly and kids do poorly quickly, and sometimes it progresses very slowly. Like I had a kid with a pulmonary vein stent placed. It was a preemie too, but he had congenital heart disease, and I operated on the congenital heart disease, and then he developed pulmonary vein stenosis and got a pulmonary vein stent. I don't remember exactly, 6 or 7 months of age, and that was 12 years ago. And he's had the same stent, and so like that's really weird. But that happens too, where the process sort of arrests itself, and you don't have to have 4 normal pulmonary veins to live, And so the problem with this pulmonary vein stenosis business is that every time you manipulate these veins, and a true sutureless repair, you don't manipulate any of them, but that won't be the case with Cece because she's got stents in place. So anytime you manipulate the veins, you sort of stir up the hornet's nest a little bit.
Thank you. Yeah, that answers a lot of questions.
Yeah, you're quite welcome. I'm going to go to Caddy next. Chincha, I know her daughter because I've operated on her at least once, if not twice. Hey, how are you?
I'm good, thank you.
But how's she doing? Okay.
Yeah, she's doing okay. We just talked really with Dr. H, and like he said, really that probably he can delay surgery till the fall or probably next spring. But I'm trying really like, you know what, we have so many really like respiratory like viruses like this past year that I probably like trying like, I mean, if she has to go for surgery in the next year or so, but I try to push it like to the summer. So probably less risk of getting something on top of like surgery.
So Caddy's daughter was born with pulmonary atresia, intact ventricular septum, and
Yeah.
has had at least 2 operations, right?
Yep, she got like a shunt when she was born, and then like the Glen at 9 months.
Yeah. And now the question is what pathway to go down, a single ventricle pathway, a biventricular pathway, or 1.5. And I reviewed her stuff last summer. I don't remember all the details of it, but this specific question that you had today was, is she suitable for a pulmonary valve replacement through the cath lab, via cath lab procedure? The answer is usually no in her scenario. The reason being, there's 2 reasons. One is that she's presumably still pretty small, and so there's a size restriction. Those pulmonary valve replacements are better done in close to adult sized human beings. And secondly, to put those in, although the technology is rapidly changing, to put those in, oftentimes you need a better landing area. And the best way to do it is in a patient that's already had a pulmonary valve placed surgically, to put a pulmonary valve in through that valve, whether it be a bioprosthetic valve or a homograft or whatever. So there's an area for the stents within the percutaneous valve to sit. The cardiology interventionists know this better than I do, but usually when it's virgin territory, it's like their first pulmonary valve replacement, a transcatheter option is not recommended.
Yeah, right now, like the plan is that they need to do open heart surgery anyway because she has an ASD that needs to be closed. They're gonna leave like a pop-off valve there, like small hole. So that's really the reason, really why like they said really that it needs to be open heart surgery. But like more my question is like, I'm not so sure if I understood correctly or no, but like her tricuspid valve is small. So what I was told really is that in her case, like other than like she's small, still she's a child really like to do that like transcatheter like valve replacement, is that the tricuspid valve is small really to allow like the valve or the catheter really like to go through that valve. So if that's the case, is that something that it's always gonna be like true for her? So she would always need open heart surgery to get that valve replaced?
That's a good question. I don't know the answer to that question. I think it really depends on what happens to that tricuspid valve over time. I think it becomes easier when she's already had one surgical replacement to put in a transcatheter valve. But you're right, the other rate limiting step is the delivery of the transcatheter valve, which has to be through the tricuspid valve. Now that device is not expanded until it gets into the pulmonary position. It goes in, it doesn't go in as a full size valve. It goes in as this compressed little thing, and then they balloon it open when it gets into the right ventricular outflow tract, or that area between the right ventricle and the lungs where the pulmonary valve sits. But I know that for a first time approach, that wouldn't be a reasonable option. But when she outgrows whatever pulmonary valve is put in, whenever it's determined she needs another operation, then that might be an approach that you could use depending on the size of the tricuspid valve. My question still remains, like, again, timing, because everybody always wants to do something, but you have to have a reason to do something at sometimes. So it's in this 1.5 ventricle scenario, she's got a Glen, plus she's got an O, like a small but functioning tricuspid valve, and she's got way to get blood flow from the lower body through the right ventricle out to the lungs. So it's hard to know how much better she's going to be immediately with an operation, especially if you're leaving part of the ASD open. That means her sats are de facto not going to be normal. They're still going to be less than normal. There's some blood's going to go from the right to the left across that hole.
Yeah, I think that like internally we had like this emails back and forth, really like when is the best time really like for her like to have surgery, and it's still kind of at some point. It's not very like clear really. She's doing well. She's doing well. She's doing like, she always had really like exercise intolerance, but it's nothing really major that it's impairing her life. But yeah, like I really don't know the answer. I only know really that they wanted like have it at some point. One of the things that like Dr. H wants to measure really, it's like the hemoglobin on her like blood.
Yeah.
And it's already like high. It's already over like 16, I think. Yeah, it was over 16.
Yeah, 16 is high, but it's not horribly high. So I mean, but that's a definite indication when it gets super high. Like when it gets 19, 20, then it's really high. 16 is high, but it's not horrible. I mean, normal is like 14, 140. So it's not too bad.
So we should like still probably, because like she's gonna go really for another blood work. So we should wait until it's 18, 19, really.
No, I'm not saying you have to wait till it gets to that stage,
Mhm.
but I'm saying if she's doing well clinically, the hemoglobin stays in the 16 range, and she doesn't have any symptoms, you have to ask, what's pushing you to do surgery? Because the older she gets, the bigger size pulmonary valve she's going to have too. So, which lengthens the time period between this intervention surgery and the next one, whether it be another operation or a cath or whatever, when that pulmonary valve ultimately wears out, which it will. So, you're going to have a clock ticking as soon as you start it ticking, no matter what, if they put a pulmonary valve in. So however you put a pulmonary valve in, once you get any kind of prosthetic valve inside the heart in a child, the clock is going to start ticking. So you want it to start ticking as late as you possibly can.
Yeah. And is it better really like to have, because right now like the plan is really like to have a cadaver valve rather than having a synthetic valve. And one of the advantages, yes, apparently, is that she can only be like probably in baby aspirin every other day, so she doesn't need really blood thinners for that.
Yeah, the pulmonary valve is not a good place for a metal valve.
No.
So it would be a biologic valve.
Okay. Okay, thank you, Dr. Gandhi.
You're welcome. Okay, let's move on to, so Maverick is their son. So they sent me a bunch of stuff. So I reviewed it and it helped quite a bit. Like I don't have all the information, but I think I have enough to understand what's going on. So Maverick was born with, let's just say, a complex single ventricle. And his most recent, well, he had bilateral Glenn procedures, and then he had a fontan. And then what I guess I didn't appreciate from our last conversation was that the fontan takedown was months and months later, like almost a year later, right? The fontan takedown.
6 months, yeah.
Yeah, okay, 6 months later. And now the question is what to do next, to try a fontan again, to do a heart transplant. So fontans are taken down for fontan failure. And there's two types of fontan failure, broadly speaking. One of them is really early and one of them is late. So I'm going to categorize Maverick as late because it's not like at the same hospitalization as the fontan was done. That would be like an early fontan failure to me. Before he even gets discharged from his fontan, it has to get taken down. So the late fontan failures are sometimes the problematic ones in the sense that you have to figure out what's wrong. Like, why did it fail? Sometimes it's obvious. The heart's not working. It's got a bad heart. Okay, fine. Sometimes it's a leaky valve. Okay, fine. Sometimes it's a problem with the actual fontan circuit. Okay, fine. Like there's a structural problem in the anatomy that caused the fontan failure. The bigger problem is, or the other thing is small pulmonary arteries limit blood flow, and that can cause fontan failure. Now, when you can identify something, then at least you know what caused it. Whether it's fixable or not is another story. When you can't identify something specifically anatomically, then the other category of fontan failure is this ambiguous lymphatic failure, for lack of a better way of classifying it. And that seems like that's what Maverick had. So some of the most important things that you sent me have nothing to do with his heart, but the other things. So I forget if it was the MRI or something. There were lymphangiectasias. They called them lymphangiectasias, and lymphatic collections above the clavicles. So I presume he had problems with chylothorax after his fontan. And there is a mention somewhere that he had plastic bronchitis. So was he coughing up a bunch of stuff?
He was, yeah.
So if you're coughing up those, they're called casts. And if you have plastic bronchitis and you have chylothoraces and lymphatic failure, that's a big red flag. That means that somehow his body doesn't tolerate the high venous pressures or the high pressures on the right side that are a consequence of the fontan circulation. So, and that's an almost impossible thing to deal with, even sometimes after a different approach, but certainly with a fontan. There's like a zillion different treatment modalities for things like plastic bronchitis, and another one's called PLE, or protein losing enteropathy. It's all different manifestations of the same thing, lymphatic failure or recurrent chylothoraces or recurrent chyle in the pericardium. Like anytime there's a lymphatic failure, there's lots of different ways to deal with it medically. Almost none of them are a panacea, which is why there's so many different ways, because none of them actually works really well. And so the ultimate goal in somebody that's had one of these lymphatic failures from a fontan is to take the fontan down. I would be, like, I'm just telling you the truth here, I would be very reticent to redo his fontan. Like, I think that's prescription for the same or something worse happening. So the other thing on his MRI was that they mentioned something called EFE on the inside of his heart, which is, it's called endocardial fibroelastosis, is what EFE stands for, which is basically scar on the inside of his heart, which means that the heart can pump just fine, but it might not be relaxing that well because of that scar. And that can be another thing that contributes to lymphatic failure, so to speak. So I think the heart transplant option is the best. Your second question had to do with an AV fistula. So, you know what an AV fistula is?
Yeah, it's basically the connection of an artery to a vein.
Yeah. So it's a connection of an artery to a vein. So it's a cheap way to, or poor man's way, I guess, to get more oxygenated blood into the system, right? You're taking blood directly from an artery and shooting it into a vein. And it's been a treatment modality that's been employed for kids that have problematic fontans with low oxygen saturations for a while. The problem is it doesn't come free of charge. Like, I'm not talking money, I'm talking about in terms of morbidity. So when you take that blood and you direct it from an artery to a vein, even if it's a small artery to a vein, that creates more blood going to the heart. So it increases the stress on a heart that's clearly not normal. Even if his MRI ejection fraction was 50%, which is, it's not normal, but it's not horrible. But again, his relaxation function is probably not normal because of that scar. And if you're going to add more blood into the mix, that can put more stress on the heart. So it's not the wrong thing to do in AV fistula, but again, like I've said with other questions, there has to be an indication in the right time. And for me, the only time I would consider an AV fistula is if there's no other options and the oxygen saturations are dropping enough to cause a significant change in quality of life. Then an AV fistula is indicated. Like if his sats are in the 60s and 70s and he can't do anything and he's pooped out all the time and all the rest of it, fine. Do an AV fistula while he's listed for transplant. But if it's, oh, he doesn't need a transplant yet, or we're buying time, or we just want to make the numbers look better, then I would be wary about it.
So you would never do an AV fistula with the thought that he's not a good candidate for a heart transplant. It's more just to buy him a little bit of time.
Well, only if he was not a good candidate for a heart transplant. His oxygen saturations were dropping, his quality of life was limited, and you wanted to give him more time.
Right.
Like, that's the God honest truth, right? So, like, if you want him to live longer and there's no other option available, then I would do it. But I mean, there's a lot that goes into a transplant evaluation. One of your questions was, did I see anything that was prohibitive against a heart transplant? No, I didn't. I haven't seen everything though, so I can't tell you. But what I saw doesn't prohibit a heart transplant.
Awesome. Okay.
Is he on the list, or?
No, we're going up in July. So July 30th, he's planned to have the AV fistula, but we're going to do the assessment first. And if we find out he's a good candidate for a transplant, we just need to decide if we're going to do the fistula or not. That's why, we weren't sure if the fistula would affect the heart transplant, good or bad, because like his quality of life right now is fair. He goes to school every day. We were out playing hockey in the street today. Like, he gets out of breath. He gets tired really easy. His saturations are 80 at best and probably more 75, but his quality of life is fair.
Yeah, I mean, I would ask Dr. Dip Chan those questions. I know Ann Dip Chan quite well. So, like, I almost texted her yesterday, but I'm like, well, I don't really have permission to do that, so I probably shouldn't. So, but I know her very well. So, like, with your permission, if she wants to talk to me, like, I'm happy for that to happen too.
100%.
But I would ask her those questions point blank in terms of, why are we doing this AV fistula? If all the ducks are in a row to list him for transplant, then list him for transplant and be done with it. And then, nobody can ever tell you how long you're going to wait for a transplant. Like, it's a crapshoot. You can wait a day, you can wait a year, but there are certain things that will point you in one direction or another, like blood type, how many antibodies he has in his system from the previous operations he's had, the previous blood transfusions he's been exposed to, all the rest of it. There are certain red flags that are like, oh, this kid's going to wait forever because it's going to take forever to get a matching heart. And there's other red flags that are, I guess, green flags that are like, oh, he's not going to wait that long. You never know when you say not that long, it still can be a while because you still need a donor heart from somewhere. But there are certain instances where you're going to be waiting a lot longer. And that would also decrease the threshold for doing something palliative like an AV fistula to improve quality of life. But the one thing you have to remember is that nothing comes free of charge in heart surgery, right? So, like, anytime anybody wants to do anything to a kid, there's a potential risk involved, even if the actual procedure is low risk. And an AV fistula is a very low risk operative procedure. Like, it takes like no time at all to do it. It takes less than an hour. It's general anesthesia, but it's not like, you're not opening up the chest or anything like that. So it's done on an arm or a leg, wherever they choose to do it. And so usually don't spend more than a night in the hospital, if that. So it's a low risk procedure from an immediate standpoint, but there are ramifications down the line that you have to think about anyway.
Awesome. That makes perfect sense. And that's kind of where we were at, because he even struggles after a cath lab. It always takes him longer to recover. And we heard it may improve his saturations by 4 or 5% possibly. But if he's a candidate for heart transplant and we can list him, that 4 or 5%, like his quality of life, I don't know. We were just questioning if it made sense to do it. So that's been very helpful, Dr. Gandhi. Thank you so much.
You're quite welcome. Okay, I'll move on to Colby, because I see Colby's name there. And the question was, hey, how are you?
Good. Yeah, it's
Can you-
just Alessio's. We just had our appointment last week, just our 6-month checkup. And it's just about his saturations and kind of, the next step is the fontan.
Can you just remind me of the diagnosis?
Yeah, double inlet left ventricle. And then Alessio, thought please. Transposition of the great vessels.
And so far he's had what operation? Just a Glenn?
He's had the band and the Glen. You did both. He's doing great. He doesn't really show any symptoms. He doesn't get tired.
Oh,
The
so
baby that came from Ecuador.
right. So I did a band first.
Yes.
So the band is still there.
Yes, the band is definitely still there.
Yeah, that's good. So, and what are his sats now?
Right now, so when we've measured at the house, he's typically 89, 90. And on Friday, he was but 84, 85. But it was a intern measuring and they kind of rushed it. So I don't know if that
Okay.
has anything to do with it, but
And how old is he?
he's 4.
And what's his like exercise status and quality of life and all that?
Really good. Like he's playing soccer. He's kind of doing, he doesn't really, I wouldn't say he's getting more tired or anything like that. Yeah, he just runs around and does
Yeah,
whatever.
so I'm gonna sound like a broken record, but there's no rush.
Yeah.
And his situation is a little bit different than a lot of kids with single ventricle because he still has a band in place. And so that
Yes.
means there's blood getting from the lower body to the lungs across the heart. So that's a good thing. And that I leave that band in place for a bunch of different reasons, but one of them is to protect against these other things that can happen with the gland circulation that presumably won't happen with him because he has that band in place and he has that blood flow that persists. So at some point he's going to need a fontan, but
Yeah.
like if it was me, I'd say not now because there's no real reason to do it now. What does he weigh?
He's 35 pounds.
55.2.
Yeah, he's good
Yeah.
for weight.
Yeah. So
The thing is that when we went to the appointment last Friday, kind
yeah,
of like the cardiologist says, like we need to do a CAT, and actually they called me today to schedule the CAT for this Friday, which like I feel like it's pretty rushed, but I don't know.
well,
And
I mean,
they said
a cath's not a, he's going to need a cath.
Yeah.
So if they sometimes a cath can be reassuring too, because if the numbers are all good, then it
Mhm.
says, okay, well, let's wait till 2025 and revisit it then. If there's something off on the numbers, then they might say, well, this is a reason we should go sooner or whatever, which is
Okay.
like if they say that, then we can talk again, or you
Okay.
know, or you can decide to do what they tell you to do. But it like a cath should be a low risk procedure and it'll give you more
Yeah.
information. It doesn't commit you to doing a fontan. It just means
Okay.
more information. But my guess is not, I mean, I don't know what they know, and I obviously haven't seen him for quite a while, but my guess is the cath will be fine. And they'll say you can wait till 2025.
Okay.
Mm.
Yeah, they mentioned before waiting till 2025 before, and then all of a sudden, and she said like his heart looks good, there's space. She didn't say there was anything off. She just said his sats are a bit lower, and that was
Yeah,
kind of
like I would take one reading,
yeah.
one isolated reading with a grain of salt. And it's not like 85 is bad. Even if they are 85, fine.
Mhm.
But
Yeah.
part of it is not just one oxygen saturation reading. It's also what happens with exertion, right? Like,
Mhm.
you know, you take a reading on somebody in an office somewhere versus after they've been out running, playing hockey, whatever. And
Mhm.
if you notice that he's getting winded more, his exercise tolerance is decreasing, that's a different kettle of fish. But if he's able to do what he's been doing, and generally speaking, his oxygen saturations are reasonable, then
Mhm.
like a one-off reading is not necessarily the reason to do something. But that's another reason, though, that a cath is sensible, because sometimes these little veins open up after a glen. These little veins can cause desaturation. If let's just say it's real. Let's
Okay.
just say his sats are 80, not
Mhm.
even 90. Let's say they're 80 and persistently 80. Sometimes it's not because they need a fontan, but sometimes it's because these extra little veins open up and they can put a plug in them. And when they plug those veins, the sats go back up and it buys you more time.
Okay. Okay.
Mhm. Yeah, I think like her concern was that the literature, it says that it's between 2 to 4 years, the best time to do the fontan, and the older the kid gets, the more complications, I guess.
Well, I don't know about that. I think you don't want to let them get super old. Like you don't want them to be a teenager when you're doing a fontan. But the difference between doing a fontan at 4, 5, 6 years of age, there's no difference.
Okay. Excellent.
All right.
Thank
Thank
you.
you so
Yeah,
much.
we really appreciate that.
You're quite welcome. Let's see. Kayla Camo. I don't have a question from you. Do you have a question? Nope.
Oh, hi. I don't
Hey.
actually. Is that okay that I'm just
Oh no,
creeping and listening?
it's absolutely 100% fine. I just want to make sure that all the bases were covered and that you didn't have something
Oh,
specific.
okay. No, thank you. I just like got from the Canadian Fontan group. I like attended the Fontan information a couple weeks ago. My
Okay.
daughter is now 17. You did her Fontan 14 years ago,
Oh wow.
and she's doing great, touch wood, but I'm just listening in. So I don't actually today
Well,
have a
it's
question.
a pleasure to know that she's doing well 14 years later.
Yes. So
That's
much thanks to you. Yeah.
Oh, well, that's fantastic. Speaking of which, Tony Sykes is on this call too. And Tony is a little older than the average child. I won't divulge your age, Tony, but you're not as old as me, but you're, a decade or so behind probably. But Tony was born with coarctation and a bad aortic valve, right?
Yes.
And I got involved with him probably about 12 or 13 years ago and replaced the aortic valve. And he looks really good right now. He had it replaced a few months ago at St. Paul's Hospital, but I think he's a good inspiration for all the other parents on this call for what congenital heart disease can look like later on in life.
Yeah, it's actually, as a kid growing up, like I had my very first open heart surgery in 1976. And, maybe I was only 5 at that time. But one of the things that I think that my parents did well is they never ever made me feel like that there was something wrong with me. I remember back in the 70s, Steve Austin, the $6 Million Man, was popular on television. So when I was at the hospital, they brought me a Steve Austin doll. So, here I am hooked up. I've got all the stuff connected to me. I thought I was the bionic kid growing up there. And that's why I was in the hospital. And I don't think they ever said anything to make me not believe that. But as a kid growing up, there was nothing that I did not do. Like there was nothing that I would say that held me back from doing sports or anything like that. So as a parent, I think one of the best things you could do with someone with congenital heart disease is treat them as if everything is normal. And as a kid growing up with congenital heart disease, and now as an adult still living life with congenital heart disease, heart failure is probably one of the number one or one of the high causes of death. There's cancer, but heart disease, I think, is definitely up there. And I think if you've got congenital heart disease, you're going to be monitored throughout the growth of your life. And I think you're going to be priority, or hopefully as high of a priority as you can in the medical system, but you will be followed throughout your life. And I think that as a kid with heart disease growing up is going to make you feel a little bit more confident. And as a young adult going through with heart disease, it's also going to make you feel more confident.
Yeah, well, that's those are inspirational words, and I don't know how many of the other parents are old enough to remember $6 Million Man, but I remember the doll. I remember it well. It's a good analogy. Certainly none of the kids these days will remember it, but I guess there's other Transformer-like things that are similar. Let's see. There's a couple other people on the call that there's no questions from, but if anybody has any other questions, I'm happy to entertain them. We're going to try to expand this a little bit too, in terms of smaller group sessions. I mean, this isn't a big group anyway, but smaller group sessions or one-on-one sessions where you can just book time with me through the internet, and we'll send out that information as soon as all that's sort of set up. But Tony Holbrook's working on all that stuff with his team, and so hopefully that's something that comes to fruition in short order to help more parents. But the more you guys can put the word out there that these sessions exist, they're going to be the second Tuesday of every month, the better it is. Like the more participation, the better. This is for the parents and the children. It's not for me. So it's anything I can do to, again, make the pathway a little bit clearer for parents that are undergoing this sort of stuff with their kids. I'm happy to do.
Dr. Gandhi, I have a question, but it's probably very specific to where we are. Daniela, when she goes really like for surgery, she's gonna have this doctor that is from the other province really, and he's gonna come. He comes every like 2 weeks on, 2 weeks off. So one of my main concerns, and with you really like the 2 surgeries that she had, she was out of the hospital 3 days. I think that she stayed when she was a newborn for 4 days after like surgery, just because I begged you really to stay for 1 more day. I didn't really want to take her home. Was kind of scared. but she's responded well, really, both times. But I just don't really want to like risk it. Probably that she needs like an emergency like procedure after surgery. She doesn't respond well, whatever, and this doctor is not here. So how does this work, if you know, really, like because
Yeah,
they say that they work with teams and blah blah blah.
Yeah, that's a good question. I wish I had a good answer for you because I don't know. I tended not to do operations at all. I mean, I didn't take that much time off, but when I did take time off, I didn't do big operations before I was leaving town for that exact reason, because I didn't want to have a kid in the hospital that potentially needed something and I knew the most about them. So I think I don't know the answer to the question because I don't know how the system works right now. I mean, I know how it works in terms of 2 weeks here, 2 weeks there, but I don't know how that's defended. So I think you probably have to ask the surgeon and the cardiologist involved specifically those questions, because they're very good questions and they need good answers. I just don't have them.
Okay. And in the cardiac like surgery, like what is this like what she's gonna have? It's like kind of one of the simple things, because that's the way that they are trying to sell it right now. Oh yes, this is really simple, like putting a pulmonary valve, like closing an ASD. This is like super simple, kind of everyday.
Well, I don't know. I don't want to say that it's crazy, high risk, complicated surgery, but at the same time, like if your kid's having their chest open for the third time, it ain't simple, right? If your kids are having their chest open for the first time, it ain't simple. So I never use those words because I just don't like them. Simple, straightforward, to me, are not words that belong in the same sentence with heart surgery and heart disease in kids, because everything we do carries risks and complications, even if it's a simple, easy defect, whatever. Like sometimes those are the operations I got most nervous about, because those are the ones where nobody ever expects anything to go wrong. And so you get even more stressed about them. So I don't use those words, and I would never use those words for redo heart surgery, because there's always scar in there. You never know what's going to happen. So at the same time, I don't want to discourage you. Like it's a pulmonary valve replacement and partial ASD closure is not a technically complex procedure, and it's not a high risk procedure, but there's not zero risk, especially in a redo scenario. And there's never zero risk in anything. And it's certainly, the more operations a kid has had, the higher the risk is for anything.
Okay. Yeah, I mean, definitely simple. I just don't really want to be in this position where everything like can go wrong goes wrong, and there's no surgeon there like to look
Yeah,
after.
I mean, I think you have to ask those questions very specifically, and particularly in terms of the timeline of when she gets her operation, when a surgeon is going to be there, when they're leaving, all that sort of stuff. Like if the surgeon's leaving on Friday and the kid's getting the operation on Thursday, like I would pass.
Yeah, me too.
If the kid's getting the operation on Monday and the surgeon's not leaving until 2 Mondays from then that might be fine. So I think you have to, again, advocate for your kid and do what's best for your kid. But I don't want to disparage anybody. At the same time, this system is not something I'm used to, and so I think you need to ask what sort of coverage is present.
Yeah, that's what I've been trying really like to sort out really, but you know how it is here, right? The answers that you normally get. And unfortunately, we're stuck where we are. Like that's it.
Yeah, I mean, I don't know the specifics of everything, but hopefully you can get some reasonable answers.
Yeah. Thank you, Dr. Gandhi.
You're welcome. Does anybody else have any other pressing questions?
Maybe just since you're asking, Dr. Gandhi, after Maverick's Fontan, I've always had this on my mind. After Maverick's Fontan takedown, I remember his surgeon, Dr. Barron, mentioning that Maverick's pulmonary artery was small and that he tried, I just don't remember the terminology of what he tried to do during the Fontan takedown to help the size of his pulmonary artery. So if we go down the road of a heart transplant, does a small pulmonary artery have a negative impact, or does the pulmonary artery come with the new heart?
Yeah, that's a really good question. So all I know is based on one of the sketches that I sort of got, and I'm gonna make sure I got this right. The I think the biggest pulmonary artery problem with Maverick, at least based on the sketch, now it may be different if I actually saw the images from the CT or the MRI, but at least based on the sketch, the smallest segment of pulmonary artery is between the two glens, is the segment in between the two glens. What really matters and what can really impact a heart transplant negatively is if the pulmonary arteries out into the lungs, so beyond where they end in the chest and go out into the lung, if they're small out there, because you can't do anything about those. The stuff inside the chest, inside what's called the pericardial sac, you can do something about. You can make them bigger. And he might have tried to make that segment bigger. The problem when you've had two glens is that you get what's called competitive flow. And so the blood goes down each glen this way, and it tends not to go this way. And this segment of pulmonary artery in the middle here doesn't grow, which is what happened in his scenario. It hasn't grown. But in a heart transplant, you do get pulmonary artery. How much you get depends on the scenario. So here's the deal. If somebody's taking the lungs and the heart, then you only get as much pulmonary artery as you need to connect the heart to the heart. Or the pulmonary artery to the pulmonary artery. If nobody's taking the lungs, then you can have all the pulmonary artery that you want. So you can use the donor pulmonary artery to rebuild Maverick's pulmonary arteries to a greater extent, which is what I would try to do. If I was a heart transplant surgeon, like I would try to negotiate that a little bit. It's hard though, when the lungs are being taken, to negotiate it a lot, but you can still negotiate it a little bit. If you got a reasonable lung guy, there's a little bit of a balancing act that goes on there. And if you can't negotiate anything, then you can rebuild that central part. And so it shouldn't impact, the bottom line is, if it's just that central part, it shouldn't impact the outcome of a heart transplant operation. All right, well, thanks everybody for coming. Thank you, Julia, who substituted in for Tony for managing all of the technicalities of this evening. It will be up on the YouTube at some point, and you'll get a wrap-up email at some point and an invitation for the next one in June. And spread the word, and I'll say goodnight and let you all go watch the Canucks.
Unicorn.